শুরু নি তোমার মোবাইলে গিয়ে দেখো তো। আমার তো আর দেখা যায় না। Dear students, good noon everyone. So it is a time for orthopedics classes. So I am Dr. Shantanu Dhariman, Associate Professor Orthopedics here MCH, starting revision classes of your orthopedics. So I am going to talk about uh, upper limb fractures that are very much important for your exam purpose and as well as for daily practice purpose. And among them, upper limb fracture, I have uh, I have told you about various things, including clavicle fracture, proximal humerus fracture, scapular fracture, humerus fracture, supracondylar, and forearm fracture and hand fractures. So we are by 2 or 3 class we'll talk about uh, different types of we'll highlight about some fractures that are very much important for your exam purpose. Okay, so first of all we can start with the clavicle fracture. So clavicle fracture, all of you know, is the one of the commonest fracture for upper limb, especially for the children as well as for the middle-aged man. It is usually a little bit rare in case of elderly personnel. The mechanism of injury for clavicle fracture, or usually you can call that this is the mechanism of injury for the all upper limb fracture. This is the common thing, that is a fall from height or fall on outstretched hand. Okay, so this is the number one thing. So number two, there may be motor vehicle accident. It may cause due to sports injury also, may due to direct blow to the shoulder or direct injury to the clavicle also. Okay, so regarding the physical examination of clavicle fracture, you can see that what I have told you in my class also, or in the word as well as uh, that is, if you have to start from the attitude of the limb. Okay, so first of all, what is the attitude of the limb when there is clavicle fracture patient? So usually or typically, patient with clavicle fracture came to you with his affected limb supported by his healthy limb or opposite limb. Okay, in the picture you can see that this patient has an uh, injury in his left upper limb, and that's why he is supported by his uh, yes, okay, and sorry, uh, yes, so you can see that he has injury in his left upper limb, and that's why his left upper limb is supported by a sling, and also as well as is supported by his right upper limb. Okay, so that's why attitude of the limb is very much important to him. Okay, second thing is the how what is the deformity, is there any visible deformity or swelling present is in the affected area. Okay, so all of we know there is visible deformity may present in case of clavicle fracture, especially for the displaced fracture clavicle, uh, displaced fracture clavicle, and it is very much obvious, but it should be displaced. If it is an undisplaced fracture, then the deformity will may not be visible on your examination. Rather than you may sometimes find some swelling on the supraclavicular area. That is another thing is important. Uh, so this is about the look, and another thing is that how the clavicle fracture patient presented to you. The clavicle fracture patient presented with pain and swelling at the clavicular region, as well as difficulty in the movement of the affected side of the shoulder. Though although it's not forming the shoulder joint, but there is some restriction on the abduction movement or some movement of the shoulder joint due to it is associated uh, um, uh, joint. Okay, and during physical examination, one thing must be one thing is very much important to find out whether the patient have any neurological or vascular injuries uh, uh, which is associated with the clavicle fracture, because clavicle it has a number of relation with a number of important neurovascular structures. That's why you have to evaluate that if there is associated any neurological or vascular injury. Okay, but it is a little bit uncommon. And another important thing is that you must have to auscultate the chest to see whether the patient has any concomitant chest injury or not. Okay, that is, you have to exclude if the patient has any pneumothorax or like that any other chest injury condition. Okay, you must have to evaluate that, and you have to also evaluate other bony injury if the patient has any high velocity injury that causes the clavicle fracture. That is, you have to examine the head, neck, the upper torso. This should be excluded whether there is any type of injury present or not. Okay. Regarding the evaluation of the fracture, you have to go for the X-ray. Okay. So what X-ray do you need? Is the X-ray of the affected side of the shoulder, including clavicle. Two view, you need two view. One is the anteroposterior view and another is the lateral view. These two view are very much important for you. I have shown you some other views in my lecture class, but that's not so much important here for the practical purpose. There is other thing, there is cephalic view, 30-degree caudal view. There is different type of view, but you need the anterior posterior view and lateral view of the affected clavicle or affected shoulder, including clavicle. Okay, and you have to also do the chest X-ray as well as X-ray of the shoulder and the X-ray of the cervical spine. Okay, remember that, because I have already mentioned that you have to evaluate whether the patient have any chest injury, there may be any cervical spine injury, like that, because most of the cases we sometimes find, not most of the cases, sometimes some cases we find that we just considering the clavicle fracture treatment, but we are missing the chest injury. Thus the patient become severe, or patient become a little bit in bad condition due to his chest injury, and that's why the patient develops sometimes respiratory distress, which is initially missed. So you have to consider the chest injury as well, along with the clavicle fracture. It should be must. Okay, so this is the anterior posterior view of X-ray of the clavicle, including shoulder, or X-ray of the clavicle anterior posterior view. You can see that in this film there is the fracture in the clavicle. So anatomically, all of we know that the most common area of the clavicle fracture is the that is the junction of the medial two-third, a medial two-third and lateral one-third. Okay, so this is the very much common area or very weakest point for the clavicle where the most commonest fractures occur. Although we can divide the clavicle fracture into medial one-third, medial third, and lateral one-third. And the most of the clavicle fracture occur in the medial third, that is the junction of the medial one-third, medial two-third, and lateral one-third. So that is the thing. So in this X-ray, you can see that that is the junction of the medial two-third and lateral one-third, and definitely this fracture is a displaced fracture. Okay, why this type of, and this is the cause, this deformity causes displacement causes the deformity in case of clavicle fracture, what I have told you. So why this deformity occur? This is due to the action of the muscle. What are the muscles? We know that that is on the medial side there is a strong muscle that is called sternocleidomastoid. So this pull of sternocleidomastoid pulls the medial fragment proximally and superiorly. Okay, that's why the medial fragment goes superiorly. Okay, and the lateral fragment is due to the pull of the trapezius muscle, and that's why it goes inferiorly. Okay, so that is why there is the much more displacement and deformity. So this is about the anterior posterior view. Regarding the lateral view, you can see that this is, or there is also fracture on the medial two-third, lateral one-third, and it is also displaced, but here degree of displacement is not so much visualized due to the lateral view also. Okay, so this two view is very much important for the clavicle fracture. Okay, so regarding the treatment option, that is important, two thing is important, as I have told in my lecture class to you. There are two options for any fracture treatment. One is conservative or non-operative, and another is the operative treatment, that is the surgical treatment. Okay, so non-operative treatment belongs to uh, either you can use it sling or you can use a brace. On surgical treatment is you can go for a number of thing. You can go for plate fixation, you can go for screw or pin fixation, you can also go use the titanium elastic nail. Although we know that there is no medullary cavity, but there is very small cavity, and the study shows that that's why recently we can use the intramedullary rod or elastic nail like things in the clavicle. So the non-operative treatment is the mainstay for clavicle fracture treatment. It is the mainstay. Remember that, because 99% clavicle fracture can be treated by non-operatively. Okay, very less indication for operative treatment, and there are relative indication I have discussed you later. So the main thing is that most commonly what is the use, that is a sling, that is called an arm sling or triangular sling, or you can use a figure of 8 brace. Okay, and it should be applied for 2 to 4 weeks. Okay, and you have to need gradual return to normal activities after that time by using this type of brace. Okay, so in this picture you can see that this is a figure of 8 brace. Okay, you can see this is go this way and come this way, and this is like 8 figure of 8 brace. Okay, so this is one of the option, and what we use more commonly in our daily practice, even in our work, that is the these types of arm slings or slings that are custom made thing. But historically this thing is very much important for a clavicle fracture treatment, that is the triangular sling. It is very much popular for the previous years, because as the custom made things are not available then it was used, the triangular slings are used, and even though it is nowadays also used even in the battlefield or war field to immobilize the upper limb fractures patient also. Okay, it is a very much important thing, and you have to remember the name of the triangular sling as well. Okay, so also we can use other things, that is called, we can also use the shoulder immobilizer for the clavicle fracture patient also. Okay, so the main thing is the non-operative treatment. You must be remember, because although we may accept that some source of deformity, some source of malunion, the but still now clavicle fracture can be, most of the clavicle fracture can be treated by non-operatively, and non-operative treatment or conservative treatment is the mainstay of the treatment, and it is usually done by use of arm sling or triangular sling or figure of eight bandage for 2 to 4 weeks, or in an average for 3 weeks. After that, you have to start the mobilization of the shoulder to for proper rehabilitation. Okay, so there are some indication for operative treatment of the clavicle fracture patient. Okay, so the indications are, so this is called, I have told you these are the red flags, that means it is necessary and it is absolute indication, it is the indication to do the operative treatment. Okay, first of all, that is if it is an open type fracture. Okay, so all of we know, if it is an open fracture, what is open fracture? That is the when a fracture communicate with the exterior or external environment, that is called open fracture. Okay, so any open fracture treatment, it is rather try to use to fix it from the very beginning. Okay, so open fracture of the clavicle, it is an indication. Tenting of the skin. Okay, it is very much important. If the fracture fragment has spiky projection, that may causes piercing of the skin, that is another indication for operative treatment in case of clavicle fracture. If there is any neurovascular deficit, so you have to go for you have to go for operative treatment, because you have to fix that neurovascular deficit. Okay, floating shoulder. Floating shoulder means if there is fracture in the clavicle as well as in the fracture in the proximal humerus, so that is thing the floating shoulder means, that means the floating shoulder, then you have to fix both the proximal humerus as well as the clavicle fracture also. Okay, and also I have told you that is the lateral one-third fracture, there is it is less common of the clavicle fracture sometimes occur, and if it is displaced lateral one-third of the clavicle fracture, if it is displaced, you need to go for fixation, because there is some strong ligament present in the distal or lateral one-third of the clavicle fracture. And if a patient wants earlier return to work and cosmesis, earlier return to work or cosmesis, okay, then you can go for operative treatment. But nowadays, tradition has come, that is due to all of them are very much conscious about their cosmetic purpose. That's why sometimes they needs the operative treatment. They doesn't need the conservative treatment, or they doesn't want the deformity that may appear after the conservative treatment. That's why sometimes the cosmetic purpose, nowadays the operative treatment become popularized. Okay, so you can see that in this X-ray, there's this is the fracture, displaced fracture of the clavicle, and it is very much prominent. The medial fragment is like to tenting over the skin like that, and that's why there is open reduction and internal fixation was done with plate and screw. Okay, so this is one type, and this is another thing where this intramedullary rod is given for the clavicle fracture. So these are the options. Okay, so what are the complications of clavicle fractures? I have told already you that is first complication and most acceptable complication for clavicle fracture is the malunion, because we know that it will be unite in a malposition, and we accept this and we accept the deformity as conservative treatment is very much good for the clavicle fracture. That's why this is the most common and acceptable complication for clavicle fracture still now. Non-union, sometimes it's not so much common, sometimes may occur. That time you may need for operative treatment, and sometimes there may be some neurovascular sequelae may occur if there is neurovascular damage initially occur, and sometimes patient may develop post-traumatic arthritis of the shoulder joint. Okay, so it is due to lack of rehabilitation. If you doesn't go for proper rehabilitation for a clavicle fracture, so you may face some types of this type of post-traumatic arthropathy following the clavicle fracture. Okay, so this is all about the clavicle fracture, that is I have told you. Now another important thing is the shoulder dislocation. That is very much important for our daily routine practice. It is very much common dislocation among our body. That is the shoulder dislocation. We face this regularly, this type of patient in our ward and in our daily practice and in the ward in hospital. Okay, so I think all of you know what is dislocation. Can you remember that thing? Dislocation means that is disruption of the joint, and in which there is no continuity in between the articular surface or no contact in between the articular surfaces of the bone. That is called the dislocation. Okay, so there is another term I want to utter, that is called subluxation. That's the thing, that is when there is partial disruption of a joint, when there is remaining partial contact in between the articular surfaces, that is called subluxation. Okay, I think all of you remember these two things. Okay, so what are the types of shoulder dislocation that we face? The most common type is the anterior type of dislocation, okay, which is very common. That is 95 to 97% is common, is the anterior type of dislocation. Okay, among them there are some subtypes, that is subcoracoid, subglenoid, and subclavicular. Subglenoid and subclavicular. This is the very much common thing, the anterior type of dislocation, and the other two types are posterior and inferior type of dislocation. Okay, the posterior type is very much rare, it is only 5%, and inferior type, that one is too much rare, that is less than 1%, and is usually considered as the subluxation. Okay, let's see about the anterior dislocation. Okay, these are the types of traumatic dislocation, or if you say that what is the mechanism of injury of dislocation, there are two things. One is traumatic, another is atraumatic. That means atraumatic causes may sometimes causes dislocation, especially when the patients or someone have some hyperlaxity of the joint and have episodes of some joint subluxation. Okay, this type of patient has sometimes have minor injury may causes the dislocation. It is one of the important thing, and this type of patient may uh, face or may experience the habitual type or recurrent type of dislocation also. Okay, so let's see about the anterior dislocation of the shoulder. Okay, so you can see in the picture, so the mechanism of injury of the anterior dislocation of the shoulder is it is the hyperabduction or abduction and extension or external rotation with posterior force. These things may causes uh, uh, may facilitates the to come out the head of the humerus from the glenoid through tearing the capsule of the shoulder joint. Okay, and thus causes the anterior type of dislocation of the shoulder. Okay, so there are some terms very much important regarding the shoulder dislocation. One is the banker dislocation, another is the heel sac lesion. What was that? The banker's lesion, as I have told you, when the dislocation occur, so then there is tearing of the capsule, as well as sometimes there is avulsion of the anterior inferior rim of the labrum, that is labrum of the glenoid. Okay, so that is called the Bankert lesion. Okay, and another is the heel sac lesion. So it is usually found in case of recurrent dislocation of the shoulder, that is there is a defect on the humeral head, that is on the posterolateral aspect of the humeral head, but you cannot find it in case of an acute dislocation. You can only find it in case of recurrent dislocation. Because of that, when there is recurrent dislocation, there is continuous friction on that side of or that portion of the posterolateral portion of the humeral head, and there is causes a depression over there and causes the heel sac lesion. Usually these are visible, these heel sac lesion are visible in X-ray, but Bankert lesion is not visible in the X-ray. You need to go for CT or MRI to evaluate this type of thing. Okay, so regarding the uh, 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 clinical feature of the patient for shoulder dislocation, you have to consider the X-ray. Can you see the, sorry, not the X-ray, see the picture. Okay, so you can find that the patient, how the position of the patient or what is the attitude of the patient. You can see, if you see the right side of the shoulder of the patient, you can see that this shoulder is not along with the body, it is away from the body. Patient keep the shoulder away from the body, with that is in abducted position, it is in the abducted position, and you can see his affected arm is supported by his healthy arm. Okay, so this is the first thing, that is the affected shoulder supported by opposite shoulder with shoulder in abduction. So another thing is that you can find that in the picture, that is the acromion process become prominent. If you see the left side, you can see the acromion process is not visible. Because why this is? Because there is another thing. This is, if you see the left side, this is called the deltoid prominence. When there is shoulder dislocation, there will be flattening of the deltoid prominence. That's why, that means head of the humerus is not in the glenoid. That's why there will be something depression or something flattening of the shoulder, and so that the also acromion process become more prominent. And you also find there will be the bulging on the anterior axillary fold. If you compare with the healthy side, there is no bulging. If you find there will be some bulging on the anterior axillary fold. Okay, so this is very much important for diagnosis of shoulder dislocation, especially the anterior type of shoulder dislocation patient. So this type of typical attitude may gives you the proper clue that this patient have a shoulder dislocation. There is also something on your palpation, you may find that there is sulcus sign. That means you may find, if you palpate, a gap between this acromion and the head of the humerus. Okay, if you try to insinuate your fingers through the shoulder between the head and acromion, in the normal side you cannot insinuate, but where in the dislocation side you may easily insinuate your finger. So that is called the sulcus sign. Okay, and another important thing that is very important, that is the Dugas test. Okay, what is Dugas test? If you ask the patient to touch his opposite shoulder with his arm, palm of the hand, the patient cannot usually touch properly his opposite shoulder. That is, it is the there may be restriction. It is restricted. It should be restricted. That is, the patient cannot will not allow to touch his shoulder, opposite shoulder with the affected part. This is called the Dugas state, which is very much pathognomic for the shoulder dislocation patient. And another thing is the Hamilton roller test. Okay, so what is that thing? If you see this X-ray, this is the patient with shoulder dislocation. You can see also there is flattening of the prominence. There is some sulcus sign is present on the left side of the picture. And if you come to this picture that is on his healthy side, you can see that when if you take a ruler or like a piece of bamboo stick like that, if you touches on the lateral epicondyle, and then if you like to touch to the head of the humerus or acromion, it will not touch. This is the normal side. Okay, so if you like to, whether if there is dislocation of the shoulder, if we try to touch the tip of the acromion and as well as the lateral condyle, you will be able to touch the ruler at the both point. So this is the Hamilton ruler test, and in the normal side is not possible due to this congruity of the shoulder. Okay, due to the head of the humerus as well as the deltoid. Okay, and when you go for another thing, examination, you have to evaluate whether any neurological deficit present or not. Okay, especially for the shoulder dislocation, the most common nerve that is involved for the shoulder dislocation is the axillary nerve. Because why? Because the axillary name of another name of the axillary nerve is circumflex humeral nerve. That is, it winds around the neck of the humerus from posterior to anterior. Okay, and that's why the during shoulder dislocation this nerve may be injured. Okay, so you must be cautious, or you must have to evaluate whether the patient has any axillary nerve injury or not. How do you evaluate the axillary nerve injury? The axillary nerve has two components. One is the motor component and another is the sensory component. Okay, the motor component is usually supplied the deltoid muscle, and as well as it also supplies the coracobrachialis or coracobrachialis. So we have concerned here for the action of the deltoid. As there is shoulder is dislocated and there is intense pain in acute phase, so patient you will not be able to elicit the motor activity of the axillary nerve. That's why you have to elicit the sensory component of the axillary nerve. That is, you have to elicit the sensation over the skin over the deltoid muscle. So it is a very much common thing. Name is the regimental badge area. And if you call it, if there is loss of sensation over that area, then we call it regimental badge sign. Okay, so for the axillary nerve, you have to evaluate the sensation over the skin over the deltoid muscle, and the sign will be regimental badge sign. Now, these all are for the clinical feature or how to evaluate by examination. And regarding the imaging, what do you need to evaluate the shoulder dislocation, you need a simple or plain simple X-ray of the affected shoulder, both through AP view and lateral view. So this one is through AP view and this one is the lateral view. Okay, so you see that on both view that this is the head of the humerus. Okay, and this is the glenoid cavity. So normally the head of the humerus should be within the glenoid here. Here the head of the humerus comes anteriorly and the glenoid was posterior. So this is the anterior type of dislocation. And moreover, if you see on the lateral view, it is proper. So this is the acromion, this is the glenoid fossa, this is the coracoid, and here you can see the head of the humerus is not within the glenoid, it comes anteriorly. So it is the X-ray of the anterior type of shoulder dislocation. Okay, so how do you manage this type of shoulder dislocation? So if we find this type of dislocation, so any dislocation, you know that this is orthopedic emergency. So you have to do some pre-medication before going for reduction. And after reduction, you need post-reduction immobilization as well as proper rehabilitation of the patient. Okay, so pre-medication means you have to make the patient uh, ready or fit for anesthesia, because for the dislocation the principle is that you have to go for reduction under anesthesia. Okay, so it may be either general anesthesia, either regional anesthesia, or maybe any other type of anesthesia, but you must need to go for anesthesia for reduction of the dislocation. Okay, that's why you have to need prepare the patient for anesthesia. That means you have to keep the patient nothing by mouth, you have to start an IV fluid, and with taking consent you have to send the patient for to the operating room. Okay, so there are different types of reduction maneuver for the shoulder dislocation patient. Okay, the techniques are, first of all, the most common technique is the Cocker's method, another one is the external rotation method, another is the Mills method, another is the Stimson method. Okay, so we should not go for all of this. I have just told you this method, but you have to remember this method very properly, that is the Cocker's maneuver. Okay, so what is that Cocker's maneuver? It should be under general anesthesia or with some deep sedation. So first, as the arm is already abducted position, okay, so you have to flex the elbow. Okay, and second thing, you have to gradually externally rotate the shoulder, and then you go to the external rotation up to as far as possible, and then again you take the shoulder to internal adduction, and then go for internal rotation. That is, first of all you need to go for external rotation, then you go for adduction, and then you go for internal rotation. So this is the simple way of Cocker's maneuver, by which you can reduce the shoulder in almost 100% cases. Okay, this is the way. So after reduction, how do you immobilize the shoulder? There are various methods, that is, it is, but most commonly what we use, that is our shoulder immobilizer. This is the very much common and popular method for, or you can also do the body strapping. That is, you have to keep your shoulder along with your body by some strapping or by with the crepe bandage, like that. These are custom made things nowadays, it is found in the market. That's why we use the shoulder immobilizer. Okay, and it should be kept for 3 weeks at least. Okay, so you have to, after 3 weeks, you have to tell the patient to came to you, and he have to start gradual mobilization exercises. Otherwise, this patient will may develop post-traumatic arthropathy. Okay, or on the other hand, in the contrary, if you do not maintain this immobilization for 2 to 3 weeks, the patient may experience further recurrent dislocation. Okay, so you have to maintain the this position and this type of immobilization proper for the proper time, and you have to do proper rehabilitation after removal of the immobilizers. Okay, so there are some complication may occur in type of anterior type of shoulder dislocation. That is, there may be some rotator cuff tear, there may be axillary nerve injury. Sometimes there is very much rare that may be vascular injury. Sometimes it is associated with fracture dislocation. Okay, you have to cautious about that. And lately, the complications are, if we do not go for proper rehabilitation, so your patient may develop stiffness of the shoulder, and sometimes there is recurrent dislocation. That is pretty much common thing. And another thing, sometimes this dislocation become unreduced by, as the patient will not come at the at the from the at the very beginning, or and they may go to other places, or they are maltreated by others. That's why the dislocation may be sometimes unreduced. So what will do that for the unreduced dislocation, you may try close reduction up to 6 weeks, but if it is after 6 weeks, you have to go for open reduction, especially for the young patient. Okay, this is all about anterior type of dislocation, and few words about the posterior dislocation. I have already told you it is a rare type of dislocation. It already occur only 5% cases, and there are some predisposing condition present in case of posterior type of dislocation. First, the things are, that is, the patient may have some convulsive disorder, as well as the patient may have some history of electrocution injury. That is the typical thing for patient with shoulder dislocation. If you find a patient with shoulder dislocation, posterior type of shoulder dislocation patient, you must have take this proper history whether the patient have convulsive disorder or not. Okay, so how is the attitude of the patient? In contrary to the anterior type, you can see here the posterior type of dislocation, the shoulder or arm is adducted and internally rotated. Okay, and as well as same thing here also, the deltoid prominence are lost, with a dimple appeared on the anterior aspect of the shoulder. That is just reverse to the position of the arm, is just reverse to the posterior type dislocation, sorry, anterior type dislocation, where the anterior type dislocation, their shoulder arm is abducted and externally rotated, whereas in posterior type the arm is adducted and internally rotated. Okay, so regarding the X-ray, you can find, you have to be very cautious, because it is very much difficult to diagnose sometimes. That's why it is easily missed in case the posterior type of dislocation. What do you find in the X-ray? You do find a light bulb appearance of the humeral head in AP view of the shoulder. Okay, normally if you see that, the shoulder head of the shoulder should be like that position. Okay, here you can find that the head of the shoulder, head of the humerus is like light bulb shape. That is the thing, the head of the shoulder, head of the humerus faced posteriorly, and that is the typical thing for posterior type of shoulder dislocation. And as it is not a common thing, that's why it is easily missed even by experienced orthopedic surgeons also. So regarding the management of posterior type of dislocation, you need a good analgesia, good sedation, or even you go for anesthesia, proper anesthesia, that is called general anesthesia, and you go for closed direction. And the method maneuver is simple, very simple. You go for axial traction, and you give the pressure on the humeral head on the posteriorly, and just go for external rotation of the shoulder. It is very simple thing. One first is axial traction, and go give pressure on the posteriorly to the humeral head, and go for external rotation. This is the pretty much simple way for posterior dislocation. And the last of all, that is the inferior dislocation. I've already told this. Another name is, it's called luxatio erecta. That means it is usually the subluxation of the shoulder. It is not properly dislocated. It's the subluxation of the shoulder. Here the arm is locked overhead. That means in the abduction position. That is, the hand rests over the head, and it is basically reduced by simple traction. If you go for simple traction, and then you will easily reduce that inferior type of dislocation, which is very much rare. So this is all about the shoulder dislocation. Okay, so the patients, this is all about the shoulder dislocation, which is very much common. So if I tell the summary, that is anterior type is pretty much common, it is about 95%. Posterior type is rare, which is about 5%, and inferior type, which is very rare. The anterior type patient presented to you, the shoulder is in abducted, externally rotated condition, with the arm is held by the healthy side, and you have to reduce the shoulder by Cocker's maneuver under anesthesia, definitely under general anesthesia, and you have to immobilize the shoulder with a shoulder dislocation, shoulder immobilizer, and uh, uh, shoulder, with the shoulder immobilizer for 3 weeks, and you